Well, I'm absolutely thrilled to have met yesterday and have the opportunity today to introduce our next speaker. She is an international consultant, hails from the US, and has been an international consultant for the past 14 years. She was born in the Bible Belt of the US of A, in a town called Fargo in North Dakota. Is that the same Fargo of William H. Macy? It's the movie? Okay. All right. Well, having met her last night, I would suggest that she's a formidable person when she enters a room. She's of sturdy Norwegian stock, genetically, and she does have a noticeable degree of self-confidence and a bit of a no-nonsense attitude I noted and detected last night. She has been told by many over the years that she has a remarkable likeness for Julie Andrews. Now today she's speaking on advanced practice nursing in primary healthcare and providing us with that international perspective of that. Now some things you may not know about her is that she took guitar lessons in her mid-50s and presented a recital along with 10 children. Now I was just doing the working out of that. She looks like Julie Andrews, did a recital with 10 children. I think the Von Trapp family are well and truly alive. She was the inaugural chair in 2000 of the International Council of Nurses and used to be an aggressive tennis player, an expert downhill mountain skier and a long-distance runner. She has many awards for the wonderful activism she undertakes for women's rights and the quality health care of women. She loves films, loves popcorn, they go together, and she has knowledge of 6 languages, including Urdu, which she learnt while living in Pakistan. She's passionate, she's energetic, and a heck of a lot of fun. Let's welcome to our conference our international speaker, Dr. Madrean Schober.
I'm beginning to think this is the most fun conference I've ever attended. I do have a confession, and with all the conferences that I have attended, this is the very first primary healthcare focused conference I've ever attended. So I'm very excited, and I have been excited with all the communication I've received from the organization committee and the contacts of this conference. It's truly amazing. And I thank you, Stuart. I am in that aging population, and I admire your grandmother. However, we do know in the United States right now that one of the issues we're facing with people and couples and individuals in nursing homes and assisted living is an increasing incidence of sexually transmitted infections and HIV/AIDS. So I'd want to keep an eye on your grandmother. Well, it is a fun time to, I couldn't pass that one up, and I got you know. So indeed, it's a pleasure to be here. This is not my first time in Sydney. I've been to Sydney several times. The first time it was raining every day, and as a tourist, I bought an umbrella with an Aboriginal design on it, of course. I still have that umbrella. It's the only one I've never lost. The second time I came with colleagues that were also nurse practitioners, and as one would do, we were wandering the streets of Sydney, close to the harbor, I believe, and looking for a taxi, and we came upon a very handsome man dressed in pink feathers. We later found out that you have a very famous gay pride carnival here in Sydney. I live in a gay pride neighborhood in Indianapolis, so I felt like I was at home a little bit. But in any case, it's really, really fun to be back in Sydney. And the welcome here has really been wonderful and warm, and I really appreciate that. And I appreciate the accolades and clapping for the speaker. I think it is important for me that in addition to having fun, that you also understand my perspective as far as I'm going to mention a few things about my understanding about not only the international context but Australia, and what's my filter. How am I looking at the things that are happening in the world today? 15 years ago, I was at a crossroads myself as I left a highly successful, independent clinical practice as a nurse practitioner in primary health care in the United States. I was the queen bee of my community, and there were many people that wanted to be in my position, but it was time for a change for me. And at that point in time, I was offered the opportunity and made a decision that led to my immersion in the international development of advanced nursing practice. My first project and initial contact with the International Council of Nurses was as a recipient of the Virginia Henderson Fellowship in 1999. The 2-year assignment was to study family nursing and family nurse practitioners. And as I stepped out of my familiar world in the United States, my family and friends suggested I had reinvented myself as I decided to visit 6 countries and 3 regions of the world looking at these particular roles. That particular project resulted in a monograph that ICN is on family nursing and family nurse competencies. Since that time, I have watched and been involved in the pain and the joy of many countries as they investigate the option of nurse practitioner and advanced practice roles. I've had the privilege to work with over 20 countries while also holding academic positions at Aga Khan University in Karachi, Pakistan, Hong Kong, and Singapore. I'm convinced that nurses can do more in primary health care. I have seen them do more in primary health care. I will echo what has been said already this morning: increased visibility. You need a voice. You need to keep moving forward. I'm continually amazed when I hear speakers at conferences say that nurses are the backbone of healthcare. My back is breaking. I mean, how can we be the backbone of healthcare and be invisible? And we are invisible. We need to be more visible. And that is dealing with change and becoming leaders. Not everybody wants to be a leader necessarily, but by the time I end my speech this morning, I'm hoping that you'll feel like you can at least work together in that direction. I will also say that I am a widow. I have a partner that's Scottish and British with a British passport. I have 2 children and I have 4 grandchildren. And I do have a family life, and the way my grandchildren learn anything about the world is to look at where their grandmother is at any point in time. The world is changing, and what I'd like to do, I'd like you to, again, relax. I'd like to invite you to take a journey with me around the world. You have a global passport. You can stop at any country you want to stop at. If I see you close your eyes, I may think you've gone on a holiday for just a few minutes. And during that time, I would like to describe the international development of advanced practice nursing and primary health care. I'd like to identify country-specific examples of role development and also distinguish the trends and challenges to advanced practice nursing internationally. Recently, I did a literature review, 209 to be specific, of the literature that was available, anything up to that point in time. And I was looking to identify drivers and motivations for the APN NP role for a research project that I was conducting at that point in time. And what I identified was that most often there's an identified need for APN and nurse practitioner services such as women's health, aging services, children. The initiation of the nurse practitioner role in the United States was identified as unmet services for children. However, after World War II, the clinical nurse specialist role emerged first before the primary health care role for mental health, and we were first educated as 2-year master's level clinical nurse specialists. This one, every time I read it, I sort of have a little catch in my chest because one of the strongest motivators is skill mix in healthcare workforce planning, which sounds very nice. It's The catch for me is that sometimes this is looked at as a supplement to doctor's services. And we then begin and have to be very careful that we're not again becoming handmaiden to the doctors. Unless you want, I'm not encouraging you to be a handmaiden, no. but right, we've been there, done that. But basically what does come out in the literature and what I found in Singapore is this view that if we develop a more advanced role, that the doctors will then be able to do more research and then have more time for complicated cases. Very significantly, there is a desire by nurses to move forward to nurse practitioner and advanced practice roles to enhance the image of nursing and to increase the status of nursing. And I definitely see this quite a bit in Asia. And there's a public demand for services by nurse practitioners. Those your support, our support, my support over the years of working as a nurse practitioner has been my patients and the public. They're very supportive once they become aware of what we can do. Just to give you an idea of where my thinking is and what sort of a benchmark, I wanted to present the International Council of Nurses definition for a nurse practitioner and APN. And this was developed as a result of the launching of the International Council of Nursing network for nurse practitioners and APNs in 2000, because we were sort of flailing all over the place. What's an APN? What's an NP? What's this? What's that? And so this was developed and has been picked up by many countries as part of their definition for nurse practitioners and advanced practice nurses, and it is quoted regularly in journal articles and so forth, and it's very simple. So what are the key points in this definition? Number one, you need to be a nurse. And that may seem funny, but regularly and periodically, I have people email me, and particularly doctors, and say, I'm a doctor, so can I be a nurse practitioner now? In a minute, you will see why in the United States they may want to become a nurse practitioner. The other thing is the level of decision-making, the accountability, the responsibility. As a nurse in critical care, emergency room, and so forth in the past, if I was in doubt as far as what was going on, I could communicate with a doctor and say, well, I don't do this, I don't know what's going, pass it on. But in the advanced level, at this more intense, complex decision making, the responsibility and accountability lies with you. And what that means is also being aware of litigation, indemnity, coverage, and so forth, because now we're no longer just casually, and it's not casual, but sometimes it seems casually going along performing delegated duties, but we're in the driver's seat oftentimes making the decisions. The master's degree is a recommendation, or was a recommendation in this definition by ICN. At that point in time, after the approval of the board of directors for ICN, the recognition was also there that there's such a variance as far as education for nurse practitioners and advanced nurses that there would be maybe a step-by-step process, or there would be some flexibility as far as moving in that direction. And that certainly is what we're seeing internationally, because this definition has now been out in the public domain since 2002, and we're now at 2014. So in my mind, having looked at where nurses are, wherever there's healthcare needs, there's a position in place for nurses in primary health care. We are the connection to the population, is my view. And this happens also if you should be interested and are already a nurse practitioner. The division for me, from my perspective, is the out-of-hospital setting. I have had, out of the 40 years I've been a nurse, I've worked in a hospital for 3 years, and I get nervous every time I enter a hospital because I don't really know what is going on in hospitals anymore. And when I was new to the University of Pakistan, the director of nursing wanted me to teach the nurses in her units to insert swan catheters, and I honestly didn't know what a swan catheter was. So there's a lot to be done in ambulatory care settings, and we don't have to know everything that's going on in hospitals, is my opinion. These are the program that has been organized and developed here is very interesting because I'm very interested in the presentations, particularly on nurse-managed practice and nurse-managed facilities. Any place where there's an outpatient hospital clinic, there's a potential for an advanced practice nurse or nurse practitioner, GP offices, multi-specialty polyclinics, and triage clinics. We have a growing number of pharmacy clinics right now. I understand the situation in pharmacy in Australia is a little restrictive, but in the United States, and also I've seen examples of this in South Africa, the pharmacy has their shop, if you will, and then in the corner there's a clinic staffed by nurses and nurse practitioners. Very, very common now. Also, we're seeing in shopping malls and also in airports. Senior health centers, and I'll mention more about that a little bit later. And it's interesting, in Hong Kong right now, they're putting up 40-story senior centers, living centers, where the seniors will not go out of their living residences. They are going to need some sort of access to health care, and a nurse practitioner or advanced practice nurse could do that. Oil rigs and other innovative work-related options. I put that in there because a year ago, I'm working with Oman to develop the nurse practitioner role, and we've been working on this since 2006. And I was just there about a year ago and met one of the nurses that was working on an oil rig, and you know, it's more isolated, and he was basically and essentially doing what a nurse practitioner would do, and would have been a wonderful preceptor, or will be a wonderful preceptor for a student looking for an advanced role. One of the things that occurs to me that I wanted to mention when I was presenting the definition is, again, when I'm talking about critical thinking and complex decision making, is I tend to make a differentiation between complex decision making and tasks. To me, the focus is on the decision making that takes place and less on the levels of expertise in the tasks that you do. And there's always a lot of discussion about can you prescribe and can you not prescribe, and who's going to prescribe. And I did practice illegally as far as prescriptive authority for a while. I've never been in prison, and I don't think I'm a criminal. But the issue of prescribing is interesting. It's a path to assist in your recommendations and therapeutic management for the people that you see, but it's really such a small part of what you do. It's your thinking, it's your brain that's really important when you're doing this kind of decision making. The confusion that we face, and I know Rosemary has faced this as well, is that there is no consensus on titles, role characteristics, or scope of practice internationally. In a study that was actually conducted in 2008 and published in 2010 by Pulcini et al., they surveyed 33 countries, and of the 33 countries, 14 different titles were being used to refer to advanced practice. Joyce herself oftentimes stands up and says, we've got to solve this problem. We have to have one title. Well, there's reasons. As you go from country to country, there's reasons why. For instance, in the Netherlands, they started with the title nurse practitioner, but it wouldn't translate into Dutch, and it didn't fit with the regulations they had in the country already. So they now are using nurse specialist. And the other thing that's interesting is multiple titles may be used within a country, even if you've got specific standards and regulations. Sometimes directors of nursing and nursing managers decide to be very independent. And one example of that is in Singapore, and that is a very powerful nurse was very, very supportive of advanced practice nurses, which is their title. But she knew that nurse practitioner was a more recognizable title based on the U.S. model, so that her APNs, when they went to work in the clinics, had a huge name badge, and on top it said advanced practice nurse, and below it said nurse practitioner. And she was really in error as far as regulations were concerned, but she was such a powerful nurse that everybody knew what she was doing, but they didn't, argue with her. I have been confused about what's going on in Australia. And During the 5 years I was in Singapore, I worked with 8 different Australian academics, and I don't think I'd speak Australian English sometimes. But I wanted to try to start a discussion about, do I understand the levels of nursing in Australia? And these were the 3 categories that someone came up for me. And one is that there is your clinical nurse specialist, that is related to just rather pay categories in hospital settings, and there's a higher level of education, but a lot has to do with years of service in the position. The advanced practice nurse is where I started getting confused, because I would talk about APN, which to me is a kind of nurse practitioner, but it's different than I think how you view and define the APN here in Australia, and maybe is related to the practice nurse or what the generalist nurse is doing sometimes. And then you have, I think, just under 1,000 nurse practitioners in Australia, not necessarily all of them working in nurse practitioner roles, however. If that's not correct, I'm willing to debate. You can throw eggs, but that's the best I could do in trying to sort things out in my mind. In the United States, and I just wanted to present this is contextual. Even I'm surprised at these numbers, and this was just a survey that was done by the National Health Service in the United States. There are at that time 154,000 nurse practitioners. We think there's 171,000 more now, and under the Affordable Care Act, or more commonly called Obamacare, contrary to, I think, a little bit what you're facing here, we've had a huge escalation. We're getting funding, we're getting scholarships. The pathways for nurse practitioners are opening up, and so we see that number to increase. 94% of the nurse practitioners have graduate degrees, and we're now moving into entry level of doctorate of nurse clinical practice. 76% are certified in primary care. So when you say nurse practitioner to an American nurse practitioner, we immediately think primary care. But what Pulcini found in the survey that they did, internationally, 70% of the advanced practice nurses are in hospital settings. So there's this change as you look internationally at what nurse practitioners are doing. 96% are in clinical practice, so they are practicing as nurse practitioners, and very few have faculty positions or administrative positions, which is a little bit different than what you see internationally. And one reason may be that the median salary in primary care settings for a nurse practitioner is $80,000 US a year, and that's a median. If you're in a position such as a nurse anesthetist, for instance, your salary is much higher even. And one of the problems we have with faculty is that the salaries are lower than what the nurse practitioners are making. As we have gone along, there has been an increased job satisfaction, autonomy, and respect. However, it's sort of like that warning label on the cigarette pack. We're continually facing challenges as far as the role is concerned. The more visible we are, the more of us there are, the more the American Medical Association develops new strategic approaches to defeat us. We do have 19 states now where we can practice totally independently, but then every time we win a battle, which is usually the legislative battles now, don't get me wrong, my youngest daughter is a physician, but the doctors don't really want us to be truly independent. And so one of the things they do is say, well, okay, well, you can be independent, but we will develop collaborative teams now. And that sounds nice, except I'm in charge as the physician. I'm in charge of the collaborative team. Okay. The reason I started with, I didn't mean to be a comparison, but the thing that comes to me frequently is the issue of nurse education, because there seems to be two sort of basic models. There's the US model and there's the British model, and then it looks like people are putting the model for advanced practice nursing education on top of one of these two models, and sometimes it's a little challenging to sort it out. My colleagues in the UK tell me that the title now is Advanced Nurse Practitioner. However, the position, the scope of practice is not protected A practice nurse can say that he or she is a nurse practitioner, and the public wouldn't necessarily know the difference. Let's see here. Can't read. There's a shift to more hospital-based care despite the push for primary care in the UK. There's a lack of a professional body, and I think this is really important. That's why this conference and this organization is so crucial, because if you're moving forward, you need to have a professional body behind you. And one of the things that's interesting in sort of looking at the context for the different countries is that in the United States, we tend to be self-directed and self-funded. And in the UK, oftentimes I've told that they're waiting for funding to get funding to go back to the nurse practitioner programs. And now they're beginning to think about funding themselves, particularly the community matrons. Okay, so that was just, the context was sort of a presentation of what countries are represented more commonly in the literature when you look at the literature. But there's some very wonderful examples of primary health care in other countries. And one of these countries is Botswana. And there are pockets of primary health care in other countries in Africa, but Botswana has been doing it the longest. With the independence of the government in the 60s, the healthcare reform shifted to a focus on primary health care. And so who was doing the primary health care? Nurses. They were working very hard at it and eventually said, wait a minute, we're doing all this health care, but we don't have enough education. So they requested more education. The government funded the beginning of a program for a family nurse practitioner in 1986, 1 year. That was not viewed as adequate enough, and eventually they moved to an 18-month program. And now the University of Botswana, Gaborone, has developed a master's program, and they're trying to work to matriculate these two programs so that the nurses that have taken courses or modules in the diploma nurse practitioner program then qualify to gain their master's level education. And that we're seeing in a lot of countries as far as bringing these two types of education together. These APN students, and APN is the term they've chosen in France, are in their first year or second year. It's a very new program. The program is based in Paris right now. And they are adding new programs other than this one. And one of the things that's curious about how they're proceeding is they want to be involved in primary health care, but the services right now don't value primary health care. And the other part that's a little unique is that as they struggle and start to become educated as APNs, the nursing education is totally separate from medical education. Medical campuses have seen this development of APN, and the doctors have thought, well, this is great. We'll educate our own APNs. And so I'm wondering, I'm watching, is there going to be a division as far as this kind of education? And looking at the students from France reminds me also that Europe is actually a hot spot right now. I didn't really think that there would be a lot of development in Europe, but right now Germany is newly launching an advanced practice nursing role, and they are collaborating with Ireland to look at the Irish model. And in the Irish model, in primary health care, and advanced nurse practitioner, a post has to be established and qualified and prepared for a nurse practitioner, and the nurse practitioner has to be educated and match the post. So you've got a whole sort of different system, which is related once again to funding. The other hot spot in Europe right now is the Nordic countries. At the ICN conference in Melbourne recently, the Nordic countries held a concurrent session on nurse practitioners, and there was standing room only. You couldn't get in the room because of the discussion. So this is a hot spot, and our next conference in August is in Helsinki. So I've mentioned once or twice that I spent 5 years in Singapore as a visiting scholar working with curriculum development and teaching students and and conducting research. These are all APNs. The gentleman in the blue shirt is actually an APN student. The Aru in the pink shirt is his preceptor. To become an APN in Singapore, you need to have been selected by an employer. You need to have 3 years of experience. You need to have a bachelor's degree, and then you apply for a position. The government, at this point in time, fully pays the tuition for the student, and the employer that chooses or selects the candidate pays a salary to the student. So they are financially solvent. However, if they should drop out or fail, they have to pay all the money back. So nobody fails. No one really fails. Once they complete their education, which is a 24-month full-time program, they then have to go on to a minimum of a 1-year internship before they can then apply for certification. So it's quite restrictive and regulated, which is quite representative of the system in Singapore. And the two men that you see there are actually working in an outpatient clinic in a mental health facility in Singapore, and the nurses developed a system where, in addition to paying attention to the mental health issues, they felt that they needed to pay attention to the other issues such as hypertension, diabetes, and so forth. And so they do a follow-up, an assessment, and can actually make therapeutic decisions, although they do not have prescriptive authority yet. The woman in the upper corner, left, my left, your right, works with a team that's based at National University Hospital, and she works with services to children that are having behavioral problems. And so the team of psychologists, social workers, the APN, and a physician actually review cases and actually go to the schools to work with the children in the school. The other APN has a triple role, actually. She has her own clients in a psychosis clinic. She works periodically in the emergency room to assess people as they come in for mental health issues specifically, and then she works periodically in a very small inpatient unit in the hospital. So she's sort of working across 3 different areas, if you will. Thailand is interesting in that with health reform, and healthcare reform, whether it's discouraging or positive, drives a lot of the initiatives. And with healthcare reform in Thailand in 2002, the health authority decided that they needed 15,000 nurses to work in primary healthcare. And that meant that they were going to have to educate about 1,000 nurses a year. And they developed a 2-tier system of a 4-month program for primary health care and a master's degree program. And these nurses were mainly the staffers, except for the highest level tier of primary health care for the services and for the clinics. What they found is that the nurses were enthusiastic. They had catchment areas and home visiting already, but the 4 months was not long enough. And so now all of those that are interested in staying in community health and primary health care will have to, within 5 years, go on to complete a master's degree. And you see this theme of starting. I started with my first nurse practitioner program was 6 months. And then as time went on, we saw that you had to have more education. I have some conflicted ideas about whether we need to go to the doctoral of clinical practice, but it's there, and the horse is already out of the barn, so to speak. I don't know what's happening right now with the conflict in Thailand. It's hard to know when there's conflict how that's going to affect nurses. It was mentioned that I lived in Pakistan for 3 years, and I'm working with Oman right now. The woman that you see sitting with the 2 men is the nursing director for the World Health Organization, Eastern Mediterranean region. And the moment she was appointed as nursing director for this region, her first workshop was with representatives of all countries of her region regarding advanced practice nursing and nurse practitioner. It's one of her focuses, is to have more nurse practitioners in the region. Her region, however, consists of Afghanistan, Iraq, Iran, Pakistan, Syria, Libya, so she has quite a challenge. They are making some progress with the nurse practitioner role. The gentleman in the upper right-hand corner is the chief nursing officer, and then the others below are all nurses. We're making some success in supporting. There's a lot of interest. We've met with a lot of people in Oman regarding the nurse practitioner role, but power, authority, competency, 3 issues come up when you're trying to do this. And as enthusiastic as nurses are, if you don't have the power and if you don't have the authority, enough authority, you can't move things forward very easily. And the health authority for the Sultanate of Oman is easily seduced by a very powerful doctor, and this doctor wants advanced practice nurses in his diabetic clinics. And so I think at this point in time, until we see that his needs are met, that we're probably not going to make much progress as far as a more comprehensive view. But they have 16 health centers throughout the country, and they have a law that says that no citizen of the country is more than a walking distance from any health center for seeking care. So for me, from my perspective, it's a perfect environment for advanced practice nursing or a nurse practitioner. They have a home visiting program that is in process right now, and there's a team from Wales that's actually helping them with developing that. So, what are the barriers and the challenges that we're facing? I happen to love this. This is was a piece from the Basilica di Santa Croce in Florence, Italy, and part of a representation of Dante's hell. I don't necessarily feel that we're always in hell, but you get that feeling once in a while. In general, people tend to underestimate the challenges and the difficulties faced when you're adding a new professional. When you're adding a new professional, such as a nurse practitioner, for instance, you're defining the scope of practice, as you well know in Australia, but everything that person does impacts everything else. It impacts the other professionals, pharmacy, physicians, the public. Not all countries have clear nurse practice acts or nurse practice acts that would support nurse practitioners or advanced practice roles. In the case of Bahrain, when we were investigating the roles there, they wanted primary health care nurses in triage centers, and they had a medical practice act that said that no one but a doctor can touch a person. And so that means a whole package of selling people with the idea of nurse practitioners or advanced practice nurses. Yes, we know that there's blockage by other professionals, and we oftentimes look at physicians as the enemy, but they're not necessarily the enemy all the time. The literature will support this, and my research certainly supported this, that the biggest blockages came from other nurses, particularly directors of nursing and nursing managers. And the issue that was arising, if I can use Singapore as an example, is we had nurses that were selected that were coming out of a master's degree program. They had not identified what these nurses were going to do. When they arrived on their stations, the other nurses thought they were very uppity. Who do they think they are? Just because they have a master's degree, I've got 33 years of experience, you're not going to tell me what to do. Who do they think they are walking around with a stethoscope around their neck? Who do they think they are having coffee and tea with the doctors? This kind of thing. And so there was a lot of frustration, anxiety, and blockage because they had developed a career path for clinical advancement in Singapore, and because of some of these attitudes, that advancement along the clinical career path was blocked. It's very important as you're looking at, it looks to me, and I know you have enormous challenges, shall we say, in Australia right now for a lot of reasons that look very urgent, but it's really important as you meet, as you discuss, your sessions that you have the opportunity to attend in this conference are just wonderful, and looking at and discussing with other people, how would you differentiate this? You may not all agree, but how would you differentiate this role? And that is where a lot of people fail, and I have actually seen 2 countrywide initiatives that failed because they were unable to do this and unable to defend to the authorities and the funders why this role was necessary or what it could add to the healthcare system. Lack of resources and financial resources are always a problem, but even more crucial and something that a lot of people face is lack of faculty. Who's going to teach these students? Who's going to teach these students advanced critical thinking and advanced skills? And oftentimes you'll need to develop a collaborative arrangement with medical officers, and because there is an overlap, isn't there, after all? I mean, you can have an argument about is this a nursing model or is this a medical model, but there is an overlap. And I feel very strongly that the strength of the role is based on nursing principles, but we do overlap into another professional's role. I tend to be very idealistic and think that it's possible that we could have some strategic planning as we proceed forward. We didn't have that in the United States. It was sort of hit and miss, and we've had tremendous problems. That's why we continue to have problems, I think, in the United States, in addition to the fact that the country is so large. But what I have constructed based on the research I did in Singapore was a conceptual health policy model for advanced practice nursing. When you see this model, what's in place? What do you have in place? Who has power and authority to work with you along the way? If I can use Singapore as an example again, the Minister of Health at one point in time did not believe that nurses should have an academic education, nor did the chief nursing officer, so they totally blocked, And after all, what are nurses supposed to do? Why can't they do what they're supposed to do? Whatever we're supposed to do, but I have been asked that question many, many times. And, but what happened is that the Minister of Health changed. When the Minister of Health changed, a new chief nursing officer was appointed, a new medical director was appointed, and a new director of the medical school was appointed. And all these people worked together and things started to move forward. So this idea of power and authority and who you connect with, and maybe 1 or 2 champions that assist you. I think by now we've all said that nurses are contributing to a dynamic change in primary health care. I think that's clear. How we're going to do it is the question. There's no doubt that this is a mind shift, and this is a problem, isn't it? Because it's such a mind shift, and it's out of the realm of what people sometimes are used to seeing nurses do. But I do believe very, very strongly, or I probably wouldn't be here with you today, that however you decide to develop your advanced practice roles or nurse practitioner roles, that those roles will be definitely part of what you do in primary health care for the future. So one of the things I wanted to do before I finish today is to leave you with something that I hope is inspiring, in addition to thinking about the challenges of policy. And that is to contribute to your desire to maintain the vitality and innovative thinking needed for nursing and the future of these roles in primary health care. So if you don't mind, in closing, I would like to share the following story from the Musnavi Jalaluyu Rumi. Perhaps you have heard it before, but I think it is worth repeating. And the story is related to the disagreement as to the description and shape of the elephant. The story is as follows. The elephant was in a dark house. Some people had brought it for exhibition. In order to see it, many people were going into that darkness. As seeing with the eye was impossible, each one was feeling it in the dark with the palm of the hand. The hand of one fell in the trunk, and he said, "The creature is like a water pipe." The hand of another touched its ear, and to him it appeared to be like a fan. Another handled its leg and said, I found the elephant to be like a pillar. Another laid his hand on the back and he said, "Truly, this elephant is like a throne." Similarly, when anyone heard a description of the elephant, he understood it only in respect of the part he had touched. Based on the place of their view of their statements describing the elephant, all differed. If there had been a candle in each one's hand, the difference would have gone out of their words. The eye of the sense of perception is only like the palm of the hand. The palm hath not the power to reach the whole elephant. You can say that your view is limited by your perception of the knowledge you have encountered at any point in time. In this story, each hand fumbles over some part of the elephant, and none is able to relate to the part of the whole. The whole of the issue of general nurses and nurse practitioners, in my opinion, in primary health care, is often so complex that it appears impossible at times to grasp the whole reality of what this means. Healthcare planners, governments, professionals, scholars, and the public are increasingly alert to the need to evaluate, reassess, and redesign provision of primary health care services. I hope that many of you will be part of this process. Thank you.